Hello everyone, Dr. David Warmflash with another flash moment in physiology or medicine. I said physiology or medicine, just like the Nobel Prize in physiology or medicine. Maybe that's why I have one of these science t-shirts on today, but you can't read what it says. So I'll tell you. It says, vaccines work, GMOs are safe, everything's a chemical. So let's get started. I want to ask you a question. What Italian anatomist, physiologist, and physician who lived about 300 years ago has a maneuver named for him that astronauts use inside their spacesuits and that you use and everybody uses when you excrete your bowels and also when you laugh and when you cough? And you may also use it when you're examining a patient to tell the difference between the causes of a murmur inside the person's heart. Well, the anatomist and physician that I'm talking about is Antonio Maria Valsalva, and I'm talking about his famous Valsalva maneuver. Here's a Valsalva maneuver. I expired against a closed glottis, meaning the glottis, first of all, is when your two vocal cords come together. That closes off the separation. It forms a separation between the upper respiratory tract and the lower respiratory tract. So it allows you to lock in the pressure. That could be really, really useful. For example, inside the head, you can use it to open up the eustachian tubes when you're in a situation when the pressure has changed between the outside environment and the pressure in the middle ear. For instance, when you are going from a low pressure situation to a higher pressure situation, in which case there would be pressure put on the tympanic membranes inside your ears, which if it gets to be a big pressure difference, that could cause barotrauma and rupture the tympanic membrane. And you don't want that to happen, and it's very painful. Now, that would happen, for example, if you're on an aircraft that's beginning its descent, or if you're scuba diving and you're going down to a deeper location. You have to clear it. And there's a more powerful way to do Valsalva, where you actually hold your nose and do it like this. I actually felt a popping in my ears. But don't try that at home unless you're really practiced in it, because you overdo it, but you could actually cause a pressure difference that actually causes a rupture of the tympanic membranes, although you'd have to do it really, really hard. Now, when you're in an aircraft about starting its descent, the pressure starts to go up in the cabin. Why does that even happen? Don't they pressurize the cabins of a passenger aircraft? Yeah, they do. But they're not pressurized all the way up to sea level. So typically, if you're in an aircraft that's cruising at, let's say, 15,000 meters, well, the cabin pressure inside might be the equivalent of, let's say, 2,500 meters. So it's as if you were a little bit higher than sea level, high enough for there to be some difference, but not the lower pressure that it would be if there were no pressurization at all. And some of the newer aircraft are pressurized to still higher, and there are special aircraft, such as certain medical transport aircraft, that actually are pressurized all the way to sea level. But in any case, you're going from a higher altitude to a lower altitude, so the pressure inside the cabin, because of the way that the system works, as the aircraft goes down, the pressure still goes up, even though it never actually equals sea level until you get down to sea level. And when that happens, a couple of things happen. You're going to feel pressure inside your ears, and you're also going to get a headache because you can hear all the babies and the toddlers crying. Wah, wah, wah. Why are they crying? They're crying because they don't know how to do a Valsalva maneuver like you do by doing this or by chewing gum or something. They only have one way they can do a Valsalva maneuver, which is by accident. So they're crying and crying until they accidentally Valsalva. But then you do it, it clears up, everything is fine because you've opened up the eustachian tube, thereby equalizing the pressure between the atmospheric pressure and the middle ear. Now, there's another thing you can do with the Valsalva maneuver. You can increase the pressure inside the intrathoracic cavity. And you can also do it overall to just keep pressure on blood vessels, or to keep pressure on your gastrointestinal tract. And actually, pilots of high-performance aircraft will also do a Valsalva maneuver, kind of the maneuver you would do when you're trying to excrete your bowels, except they do it in a certain situation when they're in what's called a high G situation, where the aircraft is doing either a turn at a very high speed or it's pulling out of a dive. It's going to do what's called increase the G forces, where the person ends up weighing a lot, multiple times more than his or her actual weight. Could be like 10 times your weight. That's 10 Gs. You could even be close to 20 Gs sometimes. And they have special pressure devices that are pushing on their legs, squeezing them to keep the pressure up. But they also do a Valsalva maneuver to put some added pressure, because otherwise the blood is going to be pulled down from the brain and they could pass out and crash or something, which is very dangerous. Now, because the Valsalva maneuver can give you increased intrathoracic pressure inside the intrathoracic cavity, it's very useful in a physical exam if you're trying to evaluate the causes of different murmurs. Now, a murmur is when you get a sound because the blood is got its hemodynamics all messed up. So you've got like an area of turbulence, such as very, very high blood flow through a region because there's a narrowing. That's a typical way that happens. Why is there a narrowing? Well, you could have a stenotic valve. The valve is too narrow. That happens frequently with the aortic valve, aortic stenosis. It also happens with the mitral valve a lot, mitral stenosis. It can happen with the pulmonic valve, and it can happen with the tricuspid valve. It's not as common. Now, you also have valve insufficiency, which is regurgitation, meaning that the leaflets of the valves do not close completely or do not close at all when it's time to close up the wall, the septum through which the blood was traveling from an atrium into a ventricle or from a ventricle into either the aorta or the pulmonary artery. You want the blood going in one direction, basically. Any of that can cause a murmur. And there are different ways you can evaluate if the murmur is due to one valve or another, or due to insufficiency, regurgitation, or due to stenosis, based on where you are in the cardiac cycle, and also based on the location over the chest, where you have the best way to hear a particular valve. If you use this kind of old invention, the stethoscope, you can put it over certain areas of the chest to evaluate certain valves. Aortic valve, you want sternum, upper sternum area on the right. Upper sternum to the left is better for the pulmonic valve. Move down a little lower on the sternum, you get the tricuspid valve. And then also on the left, out a little and lower, is the mitral valve. But there are situations when that may not be enough, and you have to use certain maneuvers to tell the difference. Now, let's just go over a little bit about stenosis of a valve versus regurgitation of the valve in terms of the cardiac cycle, where you got systole, which is when the ventricles are contracting, and diastole, when the ventricles are relaxing. And you have, first of all, you got passive flow of blood from the atrium into the ventricle, and then you've got an atrial kick happening to give it that extra oomph, getting the blood through, an extra 20 or 30% of power, pushing it through. That happens during diastole. If blood is going backward through the mitral valve, that's mitral regurgitation, that's happening during systole, because the left ventricle contracts, trying to get the blood through the aortic valve, but the leaflets of the mitral valve are not closing completely, so some blood will regurgitate back into the left atrium. That will cause a murmur, because it's not the normal blood flow. Where would that murmur be located? Be located over where you can hear the mitral valve, which is a left border a little bit down, okay? Now, what if you hear a murmur over the aortic valve, which is here is where you hear it, upper sternal border on the right, and you hear that also during systole? Well, that's not going to be mitral regurgitation. That's going to be aortic stenosis, because if the aortic valve is stenotic, there's not as much room for blood to get through, and as the left ventricle contracts, you get a murmur over the aortic valve. Unless it's not because of the aortic valve, because there are other things that can cause a systolic murmur. And there are different places where you can hear these murmurs, but let's say you have hypertrophic cardiomyopathy, another cause of systolic murmurs that they like to put on those exams that you take. Now, there's a very big difference in the patient population between who gets aortic stenosis, which tends to be the people who get atherosclerosis. People who get coronary artery disease tend to get aortic stenosis. Older people, smokers, people with risk factors for coronary artery disease. And then those are not the same people who get hypertrophic cardiomyopathy. What is hypertrophic cardiomyopathy? You get excessive hypertrophy of the myocardium. And what happens is that the left ventricle is just huge. It's huge in terms of its muscle mass, and that muscle mass closes in on itself, and it causes a narrow area within the ventricle. So blood trying to flow through that narrow area, that creates a murmur, and it happens during systole, just like it happens during systole for aortic stenosis. And here's how it ties in with what we were talking about in terms of the Valsalva maneuver. The Valsalva maneuver, which is something like this, you can use this. You can have a patient do this to try to determine the difference between the causes of one kind of murmur and another. Anytime you Valsalva, because you increase the intrathoracic pressure, you are decreasing the venous return to the heart, and therefore you are decreasing the preload. If you're decreasing the preload, you're decreasing temporarily how much blood is coming through the heart, and that has the effect of decreasing any kind of murmur that is resulting from a valve problem. Okay, such as a stenotic valve, a narrow valve like aortic stenosis. Because the reason you get a murmur and the reason you get a louder murmur is you got more blood coming through trying to get through that narrow region. And there's no way you're going to make a stenotic aortic valve wider. But you can make the murmur softer by just bringing in less blood into the heart, less preload. And that happens if the patient Valsalvas. You do a Valsalva maneuver, you decrease the venous return, there's less blood coming through. The murmur of aortic stenosis and stenosis of any valve is going to get less. But the opposite will happen with another kind of maneuver, namely like squatting. Have the patient squat down. What that does is you're squeezing the blood vessels in the leg, and you're squeezing the veins, and it's going to get some blood to the right atrium on a temporary basis, a little bit more is going to come in. You're going to get an increased preload. So you're going to get blood coming into the heart. There'll be more of it. And that means there's going to be more going through all the valves, including the aortic valve. And so the stenotic cause of the murmur is going to cause the murmur to get louder because more blood is coming through. But in the case of hypertrophic cardiomyopathy, where the reason for the murmur is not a rigid valve, but a flexible ventricle that is closing in on itself, that extra blood coming in through the heart, the extra preload, will open up the ventricle more. It'll push it out, and that means you don't have that narrowing. So in this case, the murmur is actually going to soften as a result of doing the squatting. But what happens if you do a Valsalva maneuver in somebody with hypertrophic cardiomyopathy? In that case, you reduce the venous return, so you reduce the preload. Less blood is coming into the left atrium and the left ventricle, and the ventricle is going to close in on itself. The murmur is actually going to get worse. Now, there are a lot of other maneuvers you can use for evaluating murmurs. There's, gripping. There's several others. Holding the breath. A lot of things like this. But using these two that we've discussed, the Valsalva maneuver like this and squatting, you can really get a lot of insight about the hemodynamics inside the heart and in the great vessels. So keep that in mind when you are evaluating a patient with a heart murmur.